Good afternoon, everybody. Thanks for joining us today in our cardiovascular grand rounds. Welcome, Dr. Bucciarelli, and thank you for joining us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderator for this event, Dr. Héctor Medina, Director of the Cardiovascular Imaging of La Cardio. Welcome, and thank you for moderating this event.
Bueno, buenas tardes a todos y muchas gracias por su participación. Mi nombre es Héctor Medina y los estaré acompañando como moderador de esta conferencia. Les recordamos que al conectarse a esta conferencia, ustedes autorizan el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 del 2012 y nuestra política de datos personales, la cual puede consultar en www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada y el chat de preguntas se encuentra habilitado en la barra de participantes. Les agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Un agradecimiento especial a la empresa Bayer por vincularse como patrocinador exclusivo de esta actividad. Hoy tenemos el honor de contar con la participación como expositora de la doctora Chiara Bucciarelli-Ducci con la conferencia Stress CMR, a Game Changer for Risk Stratification in Patients with Suspected Coronary Artery Disease. El entrenamiento de la doctora Bucciarelli incluye haber ido a Colegio de Medicina en la Universidad de Roma, Sapienza, haber hecho su internado en medicina interna en la Universidad de Karolinska, en el Instituto de Karolinska en Suecia, seguido de un instituto quirúrgico en Vilnius University en Lituania, y un research internship en el Texas Heart Institute en Baylor College of Medicine, y un fellowship también posterior a Baylor en Sapienza, en la Universidad de Roma, y completó su entrenamiento en Northwestern University, y finalmente hizo su doctorado en Royal Brompton Hospital, afiliado a Imperial College of London. La doctora Bucciarelli es una cardióloga afiliada en este momento al Royal Brompton. Después de terminar su entrenamiento, básicamente fue la fundadora del servicio de resonancia magnética en la Universidad de Bristol y logró que fuera una de las más destacadas en todo el país. Es una experta mundial en resonancia nuclear magnética y actualmente es la Chief Executive Officer de la Sociedad de Resonancia Magnética. Tiene más de 250 publicaciones, múltiples libros y también pertenece a la Asociación Europea de Imagen Cardiovascular. Dr. Bucciarelli, Chiara, it's a real pleasure and an honor to have you today with us. I'm extremely happy that you are joining us today. Chiara, it's really great to learn from a world expert, and without a doubt, you're one of the most important cardiologists, not only in non-invasive imaging and cardiac MR, which is your passion and my passion too, but also in the general field of cardiovascular medicine. The podium is yours, and thank you so much for being here.
Thank you, Hector, for the kind invitation to be here, and thank you so much for the very kind introduction. I mean, we're good friends, and we met at many meetings, and it's really an honor to be here with you guys virtually for now, but hopefully we can meet in person anytime soon. So my task today is to share some thoughts about stress CMR. Let me see here. Open, so I'm going to share my screen and open this. Here we go. So I speak a bit of Spanish, but it's not so good. So I'm going to go with the English, but then with the questions, if you prefer, we can switch to Spanish if that's easier for everybody. So I'm going to discuss about stress. I've done a PhD on stress MRI, as Hector said. So I have a big passion on this, and I'm a cardiologist. So throughout the talk, I don't know why I heard my voice, but throughout this talk, we're going to hear about validation of CMR, the typical protocol we're going to use, randomized clinical trials on stress perfusion CMR. We're going to look at the guidelines, cost effectiveness data, how to do stress CMR, so people don't think it's so difficult to do it. We're also going to see a few cases together. And I'm going to just hint at novel technology, which is perfusion mapping, which makes the whole reporting of stress perfusion CMR much easier, and also how to train in cardiac MRI in case somebody's interested. But of course, you got Hector there. So the ischemic, just to remember that the ischemic cascade, I'm sure all of you are familiar with this, that it's really many subsequent changes that we see in the ischemic cascade. starting from decreased perfusion, metabolic changes, up to diastolic dysfunction, systolic dysfunction, ECG changes, and then chest pain. So with imaging stress perfusion, and we know we can do stress perfusion also with PET and SPECT, we can detect those early changes early in the ischemic cascade. And other imaging modalities also applies in the various steps, but obviously the sooner the better. And so we want to detect this. So why ischemia is important? We have a wealth of nuclear medicine literature that we have been learning and still learning from. And we know that if there is extensive ischemia, then it's important to revascularize. And how do we quantify this? The nuclear data shows that if there is a myocardium with 12.5% of ischemia, then that's the turning point in which revascularization is better than medical treatment. And so we're using this cutoff also for CMR, although there isn't an equivalent cardiac MRI study to assess this. What do the guidelines say? So we start with the ESC, the European Society of Cardiology guidelines. So already back in 2014, so we're talking now a few years ago, cardiac MRI, stress MRI was indicated in class 1A, so it means you must do, in patients with intermediate risk of coronary artery disease. And this is alongside other imaging modalities like stress echo, nuclear imaging, and so SPECT, and then PET perfusion. And as you notice in the guidelines, the authors don't distinguish between imaging modalities. They don't start saying one is better than the other, but they're all equally indicated. And people, cardiologists, should do what they have available, what they're good at, and what is possible locally. But what is important is that for the first time, stress CMR really enters the guidelines. And this is basically the latest imaging modality that can do stress. So it was quite an important achievement. The guidelines in 2019 continue to say that ischemia testing is obviously important. As you know, coronary CTA has been also introduced in those guidelines, but this is reserved more for patients with low risk. Whereas the intermediate risk is really the ischemia testing that still plays a big role. And altogether, all the various modalities, stress CMR, stress echo, and the nuclear techniques, obviously. So this concept of ischemia testing is still very valid, and we can discuss maybe afterwards ischemia trial and all the things around that study and the misconceptions of that study. Well, in Bristol is a city that is here to almost 2 hours west of London, is 600,000 inhabitants. So it is a bigger city, it's not huge. When I first arrived in 2010, they were doing very little stress perfusion, and then the service grew to really exponentially, I would say. And when I left, which was before the summer, we were doing 1,500 stress perfusion scans themselves. And this is normally the old service, we were doing 3,000 cardiac MRI per year. And so half of which were stresses. In fact, you see how the referrals grew over the years exponentially from 200, this is all CMR, not just stress, from 200 to 3,000. And so 15% increase. So it's just quite big numbers, I guess. And that meant that we had quite a large catchment area here in the southwest of England. So this is to say that, you know, stress CMR has increased in 10 years massively, certainly in Bristol and certainly in the UK. There is no reason why it should not grow elsewhere. I think the expertise is increasing, and you don't need anything special in your scanner to do stress CMR. Any scanner that's been sold in a radiology department in the last, let's say, 5-10 years have already inside equipment to do stress. So it's really the expertise at getting started. Just to say that in my scanner in Bristol, I was operating, so it was an MRI scanner in cardiology, operating Monday to Friday, 8 a.m. to 8 p.m. So 12 to 14 cases per day, normally 1 hour or a bit less than that, and also alternative weekends. So if you get to that volume, also the department becomes, you know, flourishes, and it works quite well. The hospital is happy, and patients are happy, and referring physicians are happy. Get good answers to your clinical queries. Stress perfusion is a novel test. It's been around for not so long, but as you look, there's been quite a bit of development in the last so many years. So this is to say that it's not, has not been improvised by any means. There's been a lot of research. As you see the initial pictures here, you cannot see anything essentially in the 90s. And then they started to be the first studies. which is really validation, single center validation in Switzerland. And then it became, single center, single vendor. So more research, then became multi-center, more research, and all this research pointed in the right direction. The sensitivity and specificity of the test to detect ischemia was quite good. And then we start seeing the multi-center studies, the MRI impact, and then finally the randomized trials. CMR is the first one in 2012, followed by the CMR 2. And more recently, we also have the MRI Inform study, which I'll present to you shortly. This is now the image quality, which is pretty good. And you see this area, this dark area here is hypoperfusion. And so this is what we'll report as ischemia. And this is in the septal and anterior wall, extended to the inferior wall. So it's a large LED territory ischemia. So the reporting is quite similar to any other modality, and the segmentation is obviously the same as well. So as I said, lots of research to validate the technique. So initially you got to persuade a lot of people that the technique works well. So we started with, the literature started with angio and PET, and you see that there was quite a good overlap between those techniques. And so you see the line for CMR is this dark one, and for subendocardial ischemia, so quite similar to PET. This other study was on an animal model of ischemia. It was on a dog model. And so there was validation with microspheres, and these dogs underwent both SPECT and CMR. And you see the correlation when you have no stenosis, so the normal flow. So you see SPECT, spheres, and MRI, they all overlap. So using spheres as the gold standard. When you have moderate stenosis, you see that SPECT doesn't detect in this particular experiment any much ischemia, but MRI and spheres, they overlap quite nicely. And when there is severe ischemia, so severe stenosis, then obviously SPECT will start to be, it's abnormal, but spheres and CMR to a greater degree, and they overlap between themselves. So you see that here the accuracy of CMR tends to be higher than SPECT when validated against microspheres. And the same we'll see in patients with the CMR study I'll show you in a second. This is another study validating stress perfusion with FFR and the cath lab, and it shows quite nicely that when you have a normal FFR, in fact, there is no ischemia. When you have ischemia on CMR, the FFR is abnormal. And I think this data was important to convince colleagues in the cath lab that a non-invasive ischemia in biomarker was FFR. This is the CMR study, which is the first randomized trial comparing CMR and SPECT for the diagnosis of ischemic heart disease. Patients underwent both tests, and then they had an angiogram as a gold standard. And you see here in blue, it's the ROC curves, so sensitivity and specificity for CMR and for SPECT. And you see that CMR performs better than SPECT in this particular study. And this is whether you use a cutoff for ischemic heart disease of 70% of under the curve was 0.89. This is the sub-study of the CMARC and is the sex differences, so women and men. You see that in female, CMR performs better than nuclear, even more so. I think it's not the CMR performs better, it's probably SPECT has some issues because the curve for male and female quite similar for CMR. So this is to keep in mind if you have a woman with chest pain and you can choose between stress imaging modalities, then possibly CMR. This data suggests that it performs better. This is the 5-year follow-up of the CMARC study, and what it showed then is essentially that the differences between SPECT and CMR became smaller, and so both the normal CMR and SPECT had an event rate which was very, very small. However, only CMR stress remained a significant predictor after adjustment to cardiovascular risk factors. And compared to SPECT, stress CMR was a stronger predictor of MACE. So all this data is relatively new. You see 2016, and there is more, in fact, that has come up recently, which is not this, but another study in the MRI Inform, as I said. This study is quite historical. This data is quite historical, but nevertheless quite important. It shows that, high negative predictive value of a negative stress perfusion CMR, whether you do with adenosine or whether you do with butamine. In fact, it doesn't really matter. So having a negative stress is quite reassuring. In other words, there is very few percentages of false positive or false negative tests. This meta-analysis also continue to confirms the same, that there is high negative predictive value of stress perfusion CMR. So reassuring data. This is more data on 48,000 patients. And this is data from the US, prognostic role of stress CMR perfusion. So quite a difference between a normal and an abnormal stress. And this is in every patient, even in the subgroups, so those with or without history of ischemic heart disease, whether they have late enhancement or not, so myocardial scarring, whether they have a normal EF or not, whether they have typical chest pain or not. So quite a diverse population, yet the data is quite consistent. And this is now the three most important randomized trials when it comes to CMR. I have to say that obviously I'm a CMR enthusiast, but objectively looking, it's the only imaging modality that has such robust data in the literature, particularly randomized trials in journals of this caliber, Lancet, JAMA, and New England, and quite recent. So the data is absolutely very strong, very robust. So this CMARC I've already presented. The CMARC 2, it was a reiteration of the CMARC 1 study, but it was it includes NICE guidelines. And the NICE guidelines, as you know, they actually mandate CT as a first-line test on everybody. But what this study demonstrated, that if you use an approach with NICE guidelines, you end up with unnecessary angiography, 29%. Whereas if you use a stress CMR, and in fact also nuclear, the rate of unnecessary angiograms is much reduced. So something to keep in mind. And finally, the MRI Inform is a New England study that got published in 2019. And this one was a stress CMR against FFR in the cath lab. And you see that there is basically no difference. And so there is it's a non-inferiority trial of stress CMR versus FFR in the cath lab. So if you gotta choose between an FFR in the cath lab or a non-invasive test, I think you got the literature now to advocate for that. Also importantly, nowadays in the healthcare systems, that money is a shortage and that it's cost effective. This is data from the US that shows if you have a negative CMR, then and also a stress an MRI scan without any scarring, then what the cost to manage a patient is minimum $54. And that also reduces downstream testing. So if you have a negative stress CMR, then you don't do an angiogram and you save the healthcare system a lot of money and also risks to the patient, obviously. There is also a cost effectiveness study of the CMARC study that reiterates the same concept that stress CMR is cost effective. So we're now shifting gear. This was the literature, quite condensed, but hopefully was quite appealing. And the literature is there, the data is there to change clinical practice. So how do we do it if you want to get started? We basically normally cannulate two veins, right and left arms. It could be two veins in the same arms. And in one, we inject the contrast agent to do the stress, and in the other one, we inject the vasodilator stress. It can be adenosine, can be regadenosine, dipyridamole, depends what you have available. And also we do the blood pressure monitoring in the right arm. The protocol is quite similar to nuclear medicine, to be honest. That's where CMR has learned. So a single line is also possible, but then you need to use a two-way tap and ensure you don't give a bolus, obviously, of adenosine when you push the contrast in the same line. We do a 12-lead ECG to start, and this is to rule out essentially advanced second or third degree heart blocks, and which are obviously contraindication for adenosine. Patients with severe asthma, also contraindication for adenosine. It's ECG gated, so we're gonna put stickers, and this is what the patient looks like, and we normally put it in the supine position, but for patients that are claustrophobic, we can put them prone, And so they basically lie on their belly and they look outside and they don't realize entirely that they are inside a tunnel. So it's quite a good way to do it. I've used that position many times and it works well. The patient is inside. So for those of you who are used to nuclear or stress echo, cardiologists feel quite comfortable to sit next to the patient because you see what's going on. You see the patient's face, if the patient gets sick and stuff. So when you start to do stress CMR, you as the physician start getting stressed a little bit, until you get used to it. You sit outside, so you're not next to the patient. You need to communicate with the patient quite clearly. You need to tell them what's going to happen so they're not scared when we give adenosine or the vasodilator. We measure the blood pressure. It can be a blood pressure compatible, a magnetic compatible blood pressure machine, but not necessarily. There you can use also traditional one and just put the cable through the door, or there are various tricks you can do. So you don't need necessarily super over fancy equipment to be able to do it. We need an injector pump similar to this. And then from an acquisition standpoint is quite straightforward. We take it for chamber view, as you see here, and then we take 3 slices. So differently than nuclear, we don't do the full volume. We just do 3 representative short axis slices. And this is for technical reasons. But we know we're covering the proximal, mid, and distal segment of the coronary arteries. So I think when there is data that it's good enough to have 3. Obviously, it would be better to have 4, but it doesn't make a huge difference clinically, and neither for the accuracy of the report. We normally start with cine images, as you see here, for chamber, short axis. So we use that to pilot the 3 short axes. We measure the blood pressure before, during the stress, and after. And there is a constant ECG monitoring, just but is a single trace and is a non-diagnostic ECG. But at least it gives a sense of the heart rate. We then do stress perfusion. And so to do that, what we give after 4 minutes of adenosine, we give an injection of a contrast-based, gadolinium-based contrast agent, which obviously it's through a vein. So it first arrives in the right ventricle, and then it perfuses into the left ventricle and then to the coronaries, and that's where you have the perfusion effect that you see here. And then we do lead enhancement with the contrast that we've been administering to the patient, and this is to see if there is any scarring in the heart, any myocardial infarction, which is not the case here. And then we repeat the perfusion without the adenosine. And you see here the perfusion now is nice and normal. Tradition is an hour scan, and now can be reduced to half an hour, frankly. So it's actually, the technology has become very, very good, and also the expertise of the doctors. I don't want to go too much into details, but just to say that you can choose between 3 types of pictures, sequences that you can use for stress perfusion, and there are guidelines on number of slices, slice thickness, and all the other technical parameters. Also for the contrast dose, there is some guidelines. It depends very much on the contrast you use, the viscosity of the contrast agent, obviously more viscous, less quick of an injection. And but normally, I mean, the guidelines is quite clear. And in fact, those are the guidelines, which I recommend you read and download if you're interested. You can get them for free in the SCMR website. And that explains you step by step what to do. This is for interpretation and post-processing, but there are guidelines also for acquisition of stress perfusion. The analysis is normally for my clinical service is visual. We just look at these images. We then play frame by frame to ensure that the hyperperfusion are genuine perfusion defects and there are no artifacts. I think that's the trouble with every ischemia, like with nuclear, it's an artifact, it's real. I think that's a debate that continues also with CMR. And so a genuine perfusion effect could look like an artifact. Nevertheless, there are various steps, and obviously it's down to experience. How to report this, but if it's only 1 pixel, obviously, wouldn't be a very significant ischemia. We need to see in how many slices and for how long that hypoperfusion is maintained. And But as I will show you in a second with perfusion mapping, I think a lot of the subjectivity is removed, and that helps also the less experienced physician readers. We can also do quantitative perfusion. It's a bit of a lengthy, if you do by hand, it's a lot of circles around the myocardium, and but we can measure ultimately myocardial perfusion reserve and myocardial blood flow, similar to PET. But the visual reading, as you see here, is actually quite straightforward. So now maybe the fun part, we try to apply in practice what I said, and so I brought you some cases. So you remember we said there's only 3 slices that we do, so it tends to be base, mid, and apex. And it's important, in fact, that we take those pictures quite accurately. The base is without the papillary muscles. This one is with papillary muscles and not papillary muscles. As you see here, there is a reduced perfusion in the anterior wall and in the septum, in the mid, and in the apical slice. So that's significant. Ischemia for CMR tends to be more than 1.5 segments. So here you got, let's say here is 1, and this is half. This is another one, so 2.5. And so it's considered significant ischemia. So you would recommend an angiogram, which, oh, sorry, I forgot that I put a little quiz. So what do the images show? And this is, I'm sure, easy for most of you. So it's the LAD territory. So this patient underwent an angiogram. As you see, there is this occluded LAD, which then got revascularized. And then we repeated a stress perfusion simply because this was a research study. I mean, we wouldn't repeat an MRI for every angioplasty that's been performed, obviously. So this one was a research study, but we demonstrated that there was no longer ischemia in there, as you would expect, before and after angioplasty. So quite a striking difference. Although you see here, there is this thin line. And if you're not experienced, you can report this as ischemia, but actually this is a dark cream artifact. So experience is definitely important to report this. So here is another case of a 51-year-old female with 2 risk factors, hypertension and high cholesterol, and she has chest pain. And so I guess she falls into the intermediate risk of ischemic heart disease. So you can choose about an ischemia testing, and you can perform any that you wish. But in my case, we did a stress CMR. So you got our usual 3 slices, base, mid, and apex. And you see, in fact, this one was not taken very well because we were too high. And this is the LVOT, left ventricular outflow tract, that we see. So that's not good, and we're missing a segment. Nevertheless, I think we see there is this inducible perfusion effect here in the mid LAD, sorry, in the mid anterior wall. And also here in the distal anterior wall, which is not present at rest. So what do the images show? Just want to give you 1 second so to think. So the answer is again LAD because of the territory in question. This is a screenshot. You see there is quite discrete perfusion effect. So this is probably borderline significant. But it is 1.5 segments. So yeah, I guess it's borderline significant. And the way I reported it is that I call this large D1 territory because I felt that if it was the LAD, it would have been much larger than this. And this was quite discrete, so suggesting a discrete vessel. On this basis, the patient underwent an angiogram, which showed indeed a stenosis, osteostenosis of the D1. I'm gonna stop here if I may. Yeah, so you see here there is a discrete stenosis of the osteo, large diagonal. There is clearly another big plaque here. So the colleague in the cath lab didn't trust the MRI report, so they did FFR here. And actually pressure wire was within the normal limits. So beautiful correlation with the MRI images that there wasn't a large LAD ischemia, but there was a discrete D1 ischemia. And so the patient was then, she had a stent placed at the ostium of the D1. This is another case. I brought a kid given the Cardio Infantile, although I noticed you just changed name of your institution. But this is a 19-year-old little boy with heart failure and anomalous origin of the left coronary artery with a course between the aorta and the PA. And he was treated with Lima to the LAD early on with a good recovery. And at 2.5 years of age, he had mild limitation of physical exertion. And you see here there is a stenosis there. And so he underwent perfusion, so SPECT, that shows extensive ischemia and in the LAD territory, which matches the angiogram. And so at 2.5 years, what they did is a surgical enlargement of the left coronary artery. And at 7.5 years of age, he had so it was good until then. And then he started developing reduced exercise tolerance with chest pain and shortness of breath. And he was on a full-on cardiovascular treatment with beta blockers, calcium antagonist, nitropatch, ACE inhibitors, and aspirin. That was his baseline ECG. You see here with the negative T waves and ST depression here, a bit in the lateral leads. And the exercise test demonstrated here the abnormalities, clear abnormalities. So the question is really what was to do next. That was a complicated case indeed, is whether to continue with medical therapy, to insert a stent. I mean, likely it was a similar issue, or repeat operation to unroof the left main ostium. Whether to do ischemia, repeat the SPECT, or try to do stress CMR because it's a kid and to avoid radiation. And we decided to go for the latter. So he underwent, he had a stress CMR. And as you see here, there is a perfusion defect in the anterior wall, in the septum, and in the lateral wall from base to apex, essentially, which is not present at rest. And there was no myocardial scarring except for a small scar in the apex, and that was the apical bend when he got operated. So this is sadly a case of a left main ischemia. Sorry, I keep answering the questions before I get overexcited. So this is a left main ischemia in this case. So they repeat the coronary. They decided what to do, and they repeat an angiogram. And what they saw that the right coronary artery was quite well developed, and there were collaterals to the left system. And the discussion was whether to continue with medical therapy, insert another stent in the LAD. Or to reoperate. And for now, it was decided back in the times that case was a few years ago to continue with medical treatment and allow for collateral to develop further and reassess in due course and continue with medical treatment, but monitor the ischemic burden now with CMR rather than SPECT because of the radiation burden. Going back to the adults, that's a case of almost a circumferential inducible perfusion effect, ischemia that you see from the base to the apex, except this segment here, the basal anterolateral segment, and which is not present at rest. So this is a case of three vessel ischemia. Sorry, keep repeating. So three vessel ischemia. Here we go. Sorry, the arrows moved. Essentially, here you got ischemia all over. So the three vessels are involved, and I think why can be sure that it's no balanced ischemia, so it's all normal, is because the inducible perfusion effect is subendocardial as opposed to transmural, and also because there is this segment that it's normal. So we do have reference to say that this is inducible perfusion effect. So differently than nuclear, then CMR has no balanced ischemia problem. And this is because it would be almost impossible to have transmural ischemia all over in every segment. And so we always have a normal reference somewhere in the myocardium. Now what techniques? So at the moment, normal protocol that we do for CMR involves the function. So we always do volumes, left and right volumes, and we do lead enhancement to look for scarring. We do edema if we think it's an acute coronary syndrome. And if it's a chronic coronary syndrome, then we do ischemia testing And so it's nice that with CMR, it's a multi-parametric, we can do many pictures to try to answer the question. There is also novel techniques called the CMR relaxometry, and for what concerns the tissue characterization, and this is the native T1 mapping on ECV, which measures exclusively the extracellular volume and distribution. But for the stress perfusion side of things, is perfusion mapping that it's really now helping to be more accurate, more precise. And on the function side of things, we have feature tracking, but that's not the point of this talk today. Just quickly on perfusion mapping, what we can do is really measure the different compartments of the heart. We can measure flow, we can do extract the maps, we do the blood volume, and we can do the interstitial volume in the heart. So really accurate assessment at the myocardial level. As you see here, is a quite complex mathematics and computing behind the scenes, but we as a cardiologist don't see all of that. Thankfully, we just get the result in the machine. And this is the sort of protocol. It's been published by Peter Kalman, who's a very talented physicist in the US. But what we get as physician, cardiologists, radiologists, is to get the inline generation of pixel-wise perfusion maps. And this is what they look like here, and this is what we report. But most importantly, also we got numbers against that, which is milliliters per minute per gram, so similar to PET, and so is a quantitative perfusion analysis that we do. And there are some initial papers. You see this is really novel sort of advancements in the last few years that you can see the traditional stress perfusion, you see the maps, perhaps they're not as nice to look at, but then you got the numbers next to it. So the combination of all of this make your report a lot more accurate. And this is some data confirming that the diagnostic performance of perfusion mapping is actually pretty good. And so this is sensitivity and specificity for the stress, myocardial blood flow, and MPR calculated in a traditional fashion. So this is just an example of perfusion case, and then you have the corresponding angiograms. You also matches that with physiology. And this was a validation study against physiology. And you see how beautifully the perfusion mapping demonstrated the reduction in blood flow as opposed to not, as in this case. So this technique essentially brings CMR quite at the same level as PET, frankly, without the need of a cyclotron. And there is a lot of application, obviously, for perfusion mapping, not just in the traditional ischemic heart disease, but also in the patients with unobstructed coronary arteries, but with microvascular ischemia. And importantly, again, this is very novel data that this quantitative myocardial perfusion has prognostic importance. And using this inline perfusion map, pixel maps, is basically applying an AI algorithm, and that's where the robustness comes into place. And finally, this is my last slide. If you want to train in CMR, I mean, obviously you got Hector on site, which is a fantastic colleague and very talented and physician, so you have a very good teacher locally. But in addition, SCMR, which is the Society for Cardiovascular MRI, provides a lot of online training. And so I invite you to visit the website and obviously come to our scientific sessions as well, because there is a lot to learn, and there is a lot of case reading opportunities as well. And with that, I'd like to thank you for your attention, and those are my contacts if you want to keep in touch after this talk. Thank you.
Thank you, Chiara. Thank you so much for a wonderful talk as always, and we truly appreciate your expertise in teaching us about this technique, and it was just great to see everything from the beginning to the protocol itself and to the impact in real cases. So wonderful presentation as always, and we're really glad to have probably the world expert at teaching us how to do it. I have a first question from Mauricio Mejia from Fundación Valle de Lili. Could you elaborate on how you do the severity grading of ischemia?
Yeah, so the vision one, I first look at the movies and the 3 slices. So I swap between base, mid, and apex and keep watching. So if I see something abnormal in the basal slice, I check the same segments in the base. Then I go frame by frame, and I see whether that dark area arrives when the contrast arrives, or whether it's actually the perfusion. And this is to try to distinguish between a true perfusion effect from a dark rim artifact. Dark rim will appear as soon as the contrast hits the cavity. And so when you do the frame by frame, you will see that. And whereas the perfusion tends to arrive few seconds after the contrast is in the cavity, because it has to perfuse in the myocardium. So that's another trick. And then you compare stress and rest. And so the rest scan in MRI is quite different from the rest scan in SPECT. And I know nuclear medicine is very popular in Latin America, so I assume you guys are doing a lot of nuclear medicine. But rest perfusion CMR, it's not a viability scan as for SPECT. For rest, we just look at the perfusion without any vasodilator stress. And if we see an abnormal perfusion in the rest, which matches the stress, that's for us an artifact. And so in other words, we acquire rest to rule out artifacts. And to do viability, we do late enhancement imaging. So that's an important distinction. The other thing I do is I also check the segments. So if I have a very large, what it looks like a very large perfusion effect in the base, and I have none in the mid, that's a bit strange. So I use some sort of clinical common sense in reporting the images. What I also do, which I haven't said in my talk, that the dose of adenosine is 140, and that's the standard one. But what I do, I actually push my patients a bit harder. And so I give 140 for 2-3 minutes, and then I push it to 180 for 2 minutes, and then I push it to 210 for 2 minutes. And I push patients until they don't develop symptoms, so suppress. And until I don't see, and so I push them until I see an increase of heart rate of about 20%. And this is also what now the recently CMR guidelines say. So that way you're ensured that the patient has been stressed enough, so to speak, as we use the double product with a sacral ergometer and stuff. In my practice, I found when I push a patient to 210, which I do in most patients, basically my confidence in reporting the images is much higher, and that's where you distinguish between an artifact and a true perfusion effect. And so that's my practice, I guess. And then it's experience, as with everything.
Thank you, Chiara, and thank you, Mauricio, for the question. I'm sorry, there's another one. There's another question. It's called dipyridamole versus adenosine. What's your preference? And I would add also, if you use regadenoson, granted it's kind of a one shot kind of soft, sweet, very.
Yes. Yeah, no, very, very good question. So in my practice, I use adenosine. So why? I guess, because it was the easiest to get hold of, is more expensive than dipyridamole, but less expensive than regadenoson. With adenosine, however, you need to kind of draw up the vials, then you need to connect, 4 tubes. So there is a bit of work in the preparation, which is not ideal. Adenosine also allows me to top up, to do this under 80 to 10, which I cannot do with regadenoson, for example. Obviously, regadenoson, I'm starting to use it in one of the places where I work, and it's actually quite handy to give a hand injection, as Hector said, very easy, and nothing to prepare, and you don't change it by weight, you just give that, that's it. And also, regadenoson compared to adenosine is more selective, and it's more selective drug, so it doesn't stimulate the chemoreceptors. So the shortness of breath effect that patients get with adenosine is much reduced with regadenoson. So that's also a pro. And also the asthmatic attacks, or the risk to have asthmatic attacks for that reason, is much lower. Dipyridamole is a very good one. It's not used in the UK very much. It's used a lot in Italy, Greece, the Mediterranean. Is a lot cheaper than adenosine, and much more cheaper than regadenoson. So that's why a lot of centers use it, quite rightly so. It's a prodrug of adenosine, which means the time to become effective is a little longer. So when you start the infusion with adenosine, you really, within a few seconds, the patient feels the drug. And when you stop the medicine, in 10 seconds, they're back to normal. So very short half-life, which makes it a nice drug in the scanner. And that's adenosine. For dipridamole, because it's a prodrug, then it has a first passage in the liver. So it takes a little longer to be effective. And then when you stop it, it takes a bit longer for the effects to go away. So that's not a downside, but obviously it's something that the cardiologist or the imager gotta be aware. And also if you have side effects, even more so, you need to be aware. But plenty of centers use dipridamole, and that's super fine.
Thank you, Chiara. I have a question that the sensitivities and specificities reported like on the mid 80s and 90s of nuclear were like on the 80s, and it was always echo, stress, echo comparison. What we saw on CMR and the other trials you mentioned, those dropped significantly. Do you think it changes in the way the cath was done, ascertainment bias in terms of using biplane or more advanced methods to look at the coronaries? How do you explain? Because it's not like a 5% or a 6%, but it's almost like a 20% drop. How would you reconcile a randomized control data with core lab, the whole 9 yards versus what they saw, in the late 20 years of the 20th century?
Yeah, well, in fact, actually, that's a very good point. It's not something I thought about it actually, but I think it's most likely it's a composite to all you said. I think techniques in the cath lab have not changed that much, but I'm not entirely sure. I think I would look into this because it's quite an interesting observation you made. So that's as far as I can go with that question. Okay.
Our CCU director, Daniel Isaza, is asking this question, and I know you have very, very strong feelings about the ischemia trial, but his answer is, do you think stress MRI would have been used in the ischemia trial? It would have, the result of the trial would be different.
Yeah, I like this provocative question, but I think the short answer is yes. Obviously, when you do a trial, you spend 1 billion, you want to do things super state of the art. And I think a stress CMR was done with like in 0.5% of the patients, so it's like basically irrelevant. So possibly yes. But the other thing I want to say about the ischemia trial, which I haven't said in my talk, is that this essentially was a trial of conservative treatment versus invasive treatment of patients with ischemic heart disease. The way it's been sold, at least in the meetings I've been going, is like, oh, CT, ischemia imaging is dead, CT to everybody. And so magically it became an imaging trial when actually it wasn't an imaging trial at all. Imaging was used, CT and the stress techniques were used as inclusion criteria for patients. So there is a lot of distortion going on in social media and other meetings, and people are pushing agendas, based on what they want, essentially. But the ischemia trial, despite the name, is conservative versus intervening and doing a PCI. So it's a management trial. It's not an imaging trial. The other thing I want to say about ischemia is I think there are the analysis is a bit flawed in the sense, if you look at the table 1 or 2, I don't remember, there were up to 25% of patients, so 1/4 of the patients were included in analysis had no ischemia or mild ischemia, when we know that the inclusion criteria was moderate ischemia. So then, obviously, if you have 25% of the patients included in the analysis that should not be part of the analysis, you wonder how that changes the result. And nobody knows the answer, obviously, because the investigators have been very good in presenting the data, but just hiding away the kind of bad parts of it. So I think this ischemia trial is very controversial. Also, I think physician, perhaps like yourself, would be nice to hear, if you believe the data, would you as a cardiologist, would you leave somebody with moderate ischemia without being revascularized? At least in my center in Bristol, the answer is no. People will see revascularized patients based with moderate ischemia if they have chest pain, because we know from the nuclear medicine literature that if you have more than that 12.5% or 20% for that matter, then it's better to revascularize. And so I think ischemia is not a trial that I particularly have in high regards.
Yeah, I knew that. Chiara, I have a question. At the Brompton, I remember they used adenosine, and the butamine was kind of left behind. But the butamine is also utilized, I remember, Sanjay Prasad saying at the time, I want to know what your attention, what your opinion is that the butamine has more risks of VT, PVCs, making the patient, which is something we see on the echo lab when we're doing stress echo, and that you're kind of far away from the patient. And that kind of limits your ability to take the patient out and intervene, beta blocker, whatnot, in terms of making him or her more stable. Is this still something that you share? That's question number one. And then question number two, on the Mario Garcia very elegant meta-analysis that he mentioned, not for stress, but for viability, you see the specificity and the negative predictive value of MRI going up significantly when you do the butamine. But when you ask Raymond Kim, he's not a believer. And I've asked him twice, and both answers were absolutely no. The technique is fine. Just let the LG be, and no, the butamine is needed. So, but anyways, those were my two questions, in particularly about the butamine.
Yeah, no, excellent points, Hector. So the butamine, so I agree with what you said. I mean, the safety profile of the drug is slightly less than adenosine. So I use it, but I reserve to cases in which I cannot do adenosine, which are not very many, to be honest, because I just avoid adenosine in those that have a second or third degree heart block, and I avoid adenosine in those that have severe asthma. In fact, actually, severe asthma would be the one that will get, most commonly the butamine. Or in patients, for example, have a myocardial bridge, in which a vasodilator drug is, it doesn't make any sense to stress with that. So you need a positive inotropic stress, and so you will do the butamine. And or anomalous coronary arteries, with a course between the aorta and the pulmonary artery, also would do the butamine. So those would be the three cases in which do it. So it's not a huge amount of patients. So we do it, so the heart rate obviously goes up a lot more than the adenosine. So when it comes to acquiring the images, you need to have skilled radiographers that know how to adjust the acquisition to basically capture the tachycardia that we would observe. The patient also feels less well than with adenosine, I guess. That's the other component. And also when you switch it off, it takes longer for the effects to disappear. So all in all, in the MRI scanner is not just, the best, I think, test to manage, because there is a lot of layers of complexity. It can be done, but it's not quick. There's a lot of things you need to look after. And so we do it only when necessary. But yeah, it can increase also the arrhythmias, so we need to be aware of that. But there is data from Eichenagel in Germany like 20 years ago that says, yes, there is more ventricular arrhythmias, but actually, not so many more cardiac arrests. So I think it's okay. In fact, I would say the biggest complication that you can expect when you do stress CMR is more a respiratory arrest because of the asthma due to adenosine, that then leads to cardiac arrest. I think in Bristol, the two cardiac arrests we had, well, one was an hypertrophic cardiomyopathy, nothing to do with stress, but the other one was a respiratory arrest, simply because the patient had asthma and the doctor hasn't quite investigated that thoroughly, and the adenosine was given and bronchospasm occurred. Now, the second question is for viability. So I think it's a good point to add the butamine, but what I do is actually, so my answer would be something in between Mario and Kim, which every viability scan request I get, I always add stress perfusion on top. And this is because the limitation of late GAD with viability is the sort of binary approach that we use to reporting. So if you have a transmurality of 100%, so the all myocardium, it's gone, and I think that easy is non-viable. If you have a partial thickness infarct and you have 25% late enhancement, it's easy. It's a subendocardial infarct. It's really in between that creates problems when you have late enhancement of 50%. So then it's tricky because, so how do you report that? You report this as viable or non-viable? because you sit exactly in between. So by doing ischemia testing, whether you do your dobutamine or adenosine, and I do adenosine, if that 50% of viable myocardium is also ischemic, then you have a strong indication to revascularize. If you don't have ischemia, then less so. And so in my experience, that has really helped adding ischemia testing. You can add dobutamine, but with all the complications that we discussed. So it makes the workflow just more complicated.
Okay, that's pretty good trick. Thank you. What about, actually, I have to make a confession because we're stealing one of your speakers from the SCMR from Orlando. Anthony Chang is going to be speaking to us in a couple of weeks about AI. And that talk, that was a great meeting. It was very persuasive in a lot of regards on how we should or we need to start adapting to AI. Do you think AI will have the same impact on stress MRI? I mean, you did a PhD on stress MRI, so the whole 9 yards of the technique. The question is, it's definitely making a huge change from what I know, from the little I know outside, cardiac imaging on chest CT, on non-contrast so far. And there's also some, publications about obviously chest X-rays, but stress MRI is probably one of the more difficult. Of course, you're an expert and you make it sound it's simple and it's not that hard. But it being as difficult as it is, do you think AI will have also the same impact that it will have on non-moving organs? Also, with all the caveats of microcirculation and all the factors that you have to put into the equation of finding ischemia, which to me it's probably one of the hardest things to find in cardiac MR.
Yeah, no, thank you, Hector. Another great question. But the answer is yes, I think AI will definitely help. I mean, it's helping already. And because I've done the PhD on stress perfusion, I spent hours and hours, drawing circles of the myocardium and of the cavity to try to measure MPR or myocardial blood flow. The role of AI is much welcomed, really, because it's hours and hours of time that is saved. With the perfusion mapping, so the AI in perfusion applies now to the perfusion mapping. So you need to acquire the perfusion mapping and then the AI applies to that. You cannot apply as yet the AI to the images I've shown you, which are traditional images. So for the perfusion mapping, it's easy. It's like reporting a nuclear scan. You just sit in front of the screen, you see the images and you got the numbers on your side. And so your reporting, it becomes very quick. And therefore, I think it will improve the accuracy, but also will improve workflow. And for the less experienced physicians, they don't just need to rely on their talent to read through the artifacts, but it will be it's a more quantitative approach. So the answer is yes.
Okay, thank you so much. There's one last question from Mauricio Mejia. We want to make sure that we have a solid 1 hour of Chiara's time, and it's late already in London. What's your experience?
No, that's fine. I'm happy to stay a few more minutes. I'm delighted.
Thank you. What's your experience using perfusion CMR in microvascular disease? That's a wonderful question. Gracias, Mauricio.
Yeah, no, great question. So with the perfusion mapping, I would say it's quite easy and most importantly is more robust. With the traditional CMR, there is a New England paper, in fact, from the Brompton that says CMR is wonderful in syndrome X, so microvascular ischemia. However, it's a bit tricky. I think personally in 15 years that I've done stress perfusion, I reported a positive microvascular disease in probably no more than 5 cases. And I've been doing a lot of CMR. So in other words, I don't think it's that easy to see it. And the risk is that it could look like you're reporting microvascular disease is something that is artifacts. On the other hand, sometimes the images are very telling, I guess. I feel more reassured. But with the perfusion mapping, it would be even more reassurance.
Okay, Chiara, thank you so much. And again, for making it like a solid 1 hour. We were absolutely thrilled to have you. Hopefully next time we'll be live. We had the plan of visiting you last year, but obviously, COVID came and everything was unfortunately need to be canceled. But it was great seeing you and having you here. Thanks for teaching us and And we're very fortunate to learn from the world expert on these very particular technique that it's not very popular here. We don't do any stress MRI here. We have been experiencing a very high volume. We also have our scanner from 6 a.m. to 6 p.m. and we're doing about 1,500 a year. But we have a new Carlos Guerrero from McGill that you work with long distance I think on a tetralogy patient, on a tetralogy project, just joined us. And we are, I mean, as you mentioned, our name is La Cardio, but 30% of our patients are peds. And pediatric population, it was the reason why our hospital was initially started. So we have a vast amount of patients that will need scan. And Carlos just trained, and he came back with, he was also with Matthias Frederick there. But it's difficult, at least for us, to think about starting a stress MRI, at least if we don't have another scanner. I think that as you mentioned, the data is compelling, but I don't know if you have a final tip of advice on how can we start putting stress MRI. We have a full magnet already. How many you have one magnet, or you have two magnets at Bristol?
So in Bristol, I had one magnet full time, and then one magnet I had one day. So
okay.
On a Wednesday was two magnets. The other week was one.
Okay.
But here in London, it's crazy. They have, the Brompton have 4 magnets.
Yeah. It's like Disneyland 4. Yeah. Chiara, thank you so much. Have a wonderful weekend and have a wonderful rest of Friday. Lo mismo para todos. Muchísimas gracias por haber participado. Chiara también habla español, yo diría que perfecto. De hecho, ha dado esta conferencia en español, pero bueno, es uno de sus muchos talentos. Chiara, un gusto. Gracias a todos por participar. Fue un placer haberte tenido y nos veremos ojalá pronto en algún sitio. Que estés muy bien.
Sí,
Gracias.
Muchas gracias. Muchas gracias por la invitación.
Hasta luego.
Y hasta pronto. Chao.
Chao.